Welcome everyone to our third Healthcare Data Matters webinar, where healthcare leaders and innovators join in conversation to set a new standard of patient-centered and data-driven care. I'm your host, Bruce Hall, and before we begin, I'd like to go over a few disclosures. First off, funding for the Healthcare Data Matters Forum is supported in part by Medical Informatics Corp. And Intel. Presenters' opinions and viewpoints are their own, and we do not pay speakers or offer any exchange for product endorsements. You can see other disclosures on this disclosure slide. Okay. Now it's my extreme pleasure to introduce our guest today, Dr. Parag Jain. Dr. Jain is an assistant professor of pediatrics at Baylor College of Medicine and practices critical care and pediatric cardiac critical care medicine at Texas Children's Hospital. Dr. Jain will be discussing how he and his colleagues at Texas Children's are working towards automating the detection of junctional ectopic tachycardia, or JET, as we'll refer to it, in pediatric populations. How are you doing today, Dr. Jain?
Good afternoon, Bruce. And again, I want to thank you. Thanks to MIC for giving me this opportunity to share some exciting work that I've been able to do in partnership with SIGBAY, trying to come up with an innovative solution for a very challenging problem that we face on a routine basis. I have no financial disclosure for myself. I am fortunate enough to have funding support for this study from Texas Children's Hospital with a pilot award. So, again, thank you for the opportunity.
And thank you so much for being with us for our third webinar. Our format today, Dr. Jain, is first, I'll ask you some questions to give you the chance to present your study to our audience members. And during our talk, audience members can type any questions they may have in the Q&A tab, as shown on this slide, and audience members will be muted throughout the presentation. We'll address as many questions as we have time for at the end of our session. Sound good?
Sounds awesome. Thank you.
Okay, very good. Let's dive right in and talk about the patient population you're dealing with and how does JET affect this patient population?
All right. So Bruce, again, I don't know how many of the people from the audience, I think a significant number would know, but congenital heart defects are the most common birth defects that affects about 1% of the children that are born in the United States. And a majority of these children require surgery to repair the defect or the hole in the heart. And whenever they're undergoing the surgery, the heart has to be, or the whole patient has to be on the heart-lung bypass machine. The surgeons usually have to empty the heart so that they can look at the holes, they can repair it and fix it. One of the most common complications after this surgery is arrhythmias. As you can imagine, like the heart has been pulled and pushed and multiple stitches have been put inside the heart. So the heart is not feeling the best, and rhythm problems are very frequent in the post-operative period. Of all the rhythm problems or arrhythmias, the most common ones that we see is, or one of the most common ones that we see is something called as junctional ectopic tachycardia. And basically what it is just that the heart is not beating in a normal sinus rhythm. It's beating at a much higher rate. And not only that, it is beating from an abnormal focus that is coming from somewhere in the middle of the heart, like the junction between the top and the bottom chambers, called the AV node. This has an incidence of about 5 to 15% and a mortality of about 10% in some centers. So you can imagine, one of the 10 children can potentially die. And so it's a pretty fatal arrhythmia that can happen. Again, we see that very commonly in post-operative period.
Okay, thanks for that background, and certainly a serious malady happening to these young children. What makes it challenging to diagnose someone with JET when dealing with a patient with this malady, and what's involved in monitoring a patient and anticipating the onset of JET?
That's a great question, Bruce. And one of the reasons why JET is such a tricky arrhythmia is, as you can see, the top picture on this diagram, the one in green is the electrocardiogram. And if you just focus on the top one, you can see it just looks the same. And to a naked eye, or if a passerby, who's not looking very closely or paying close attention to it, you can easily miss it. And JET, because of its deceptive nature, is able to make the postoperative care or the clinical situation pretty worse pretty quickly. And one of the reasons for that is it goes undetected for a long period of time. Unfortunately, the bedside monitors that we have at this time is not able to, there's no algorithm or there's no alarm built in that can alert a clinician that affects that the patient is having JET. And to give a little bit more on the nature of the problem, I work in a cardiac ICU that has 48 beds, which is one of the biggest number in the unit. So imagine like me being on call by myself at night, and there is another physician with me, so we divide the unit in two. But then even at any given night, like I'm taking care of about 20 to 24 really sick children, it's humanly, physically impossible for me to be available at each bedside. And I have to rely on these monitors, the bedside monitors, to alert the nurses who are definitely present at the bedside so that I can be informed if there's something going on with the patient that needs a clinical attention, they need to come and have a look at it. So as you can see on the top one, like how deceptive JET can be, because if you just look at the EKG, there are no obvious changes when you have this kind of arrhythmias. But what is interesting is the heart is a very sophisticated organ. Like, it has multiple functions. Like, obviously the biggest function we always think about in layman term is being able to pump the blood to the body. But then there is an electrical activity happening that is causing mechanical changes inside the heart. And what happens is, like, if you have an arrhythmia, the heart is not able to beat in a coordinated manner. And as a result of that, the amount of blood the heart can put out is significantly compromised. Especially, this is much more exaggerated in neonates. Like, so you can imagine, like, a neonate who is like 3 kilos or 4 kilos, the heart is just size of a walnut. You have only so much mass to have the blood being pumped out. So they tend to speed up their heart rate. What happens because of that is the heart is not able to fill appropriately, and there are some changes inside the pressures of the heart that makes it even harder for the heart to pump blood out. So, but what is interesting is, although the EKG can be deceptive, there are telltale signs of this arrhythmia in particular. So if you look at the second waveform, is something called as central venous pressure waveform, or CVP. And as depicted by the dotted line, there is a marked change in the morphology of the venous waveform that happened with the onset of JET. So although the EKG can be deceptive, but if we have enough training for the clinicians, we can definitely pick up these changes at the bedside and potentially can act in a timely manner. I want to finish the figure explanation, and the third part of the figure is the ABP, or the arterial blood pressure. This is the actual blood pressure that the patient is seeing. And even if you notice that, like, whenever the patient went into JET, there is a drop in blood pressure. And the reason for that is there is no coordinated activity between the top and the bottom chambers of the heart, and thus the heart is not able to perform to its maximum.
So what a visual you gave us, thinking about those tiny little hearts trying to keep up in this population. So that's quite visual there. And thinking about you going through this slide, you can identify the onset of JET looking at these types of data, but there is no alarm or early alerting, as you mentioned, for the onset of JET. So what are some of the techniques that you and your team are working on that might be able to create alerts for the onset of JET?
And I think this is where the fun part of my research is, so what traditionally we have been trained as a clinician is to just look at one piece of data, but then what we don't understand is, to the naked eye, there's only so much we can process. So what I'm trying to do with a team of mathematician and biostatistician is, we're trying to break down the changes that happen in the electrocardiogram. So what electrocardiogram is a visual representation of the electrical activity that is happening as the current in the heart travels from one part of the heart to the different part of the heart. So, like, as you can see on the left side, what we have is in blue is a typical original EKG. So this is like someone who has a normal EKG, and you see multiple humps in that one. So the first hump is what we call as the P wave. This is where the top chamber of the heart, the atria, is contracting. So this is where the first electrical activity is happening. And then as the current travels down toward the lower chamber of the heart, the ventricles, you can see a much sharp rise and fall in the electrical current that is happening because the ventricular mass, which is a lot more than the atrial mass, is contracting and making the current pass by. And as the heart is relaxing, we see the third hump, what we call as the T wave. So what happens in junctional ectopic tachycardia is the P wave typically is absent in its original position. And the reason for that is the focus for initiation of the electrical activity has changed from the top chamber of the heart to somewhere in the middle of the heart. So what typically happens in JET is both the P wave and the QRS, or the second hump, they are almost overlapping. And not uncommonly, what the P wave comes after the QRS. So there is a distinct morphologic change that happens in the EKG. So our team, what we are doing at this point is we are trying to break down the EKG morphology for each cycle, train the computer, just like how we have the facial recognition. Like, we are telling the computer, hey, like, this is the phase of a normal EKG, and then this is the phase for an abnormal EKG. So, so that the computer can then, when a next feed of EKG data is being fed into the computer, it can say, okay, it looks like a normal EKG or it looks like an abnormal EKG. And what we call this is something called as the morphologic parameterization. So what we have is we have the different features of the EKG, be it the width of the first hump or the P wave, be it the height of the P wave. We are also feeding in the width and the height of the QRS, the distance between the P and R. So we are the typical thing that an electrophysiologist would often look at when they are evaluating an EKG. So all of that information is being fed into the computer. And again, with our machines becoming so advanced, we are able to have a huge library of all that information and just trying to make the system much more smarter, so that we can even look at this minute changes that can happen with all the different variations even in JET. The two things that I talked about, the P wave might be buried under the QRS, or it could be coming after the QRS. So we are telling the computer to be mindful of all those changes, and that is the one arm of our arrhythmia detection model. The other big arm that that we wanted to build is we wanted to look at not just the electrical changes that happen in the heart, but we want to also take into consideration the mechanical changes that happen in the heart, as depicted in the second diagram on the right, called the CVP. So if you look at this waveform, you can definitely see a peak that comes in yellow or green color somewhere in the middle of the diagram. So if you try to go look at the diagram going away from you, this is how the heartbeat has been stacked up as the rhythm changes from normal to JET. And then the arrow that points it shows how your waveform morphology is significantly different in a patient with JET. So what we are trying to do is we are trying to tell the computer, okay, look at the EKG data, but on top of that, I want you to also pick up the changes that happen in the venous waveform. And then what we feel is the combination of two, where we are not only looking at the electrical activity, but we are also looking at the mechanical disturbances that happen inside the heart. As a result of that, will make it to come out as a very sensitive and a specific algorithm. So if you look at the next slide that we have over here, where on the left, you can see we have used something called as fast Fourier transformation. What that does is it looks into the changes that happens in the CVP during the normal sinus rhythm and during JET. And you can see in the blue, there is the peaks and valleys are not as marked as compared to the one in the red. There's significantly high peaks and valleys that is happening. So, and this is in the CVP. And then we have then also taken into consideration the effect of blood pressure on the CVP. And then what we found is even after we take away the consideration just of all the factors that are happening outside the heart that is contributing to the venous pressure, there is still a significant telltale sign for, especially for this particular arrhythmia like jet. And if you look at the picture on the right, like there's like a significant difference between the power of this particular signal, like looking at the CVP morphology changes that happened. And what we did is we went a step ahead. We even took out the factor of the heart rate. So like, because this will be also a little bit affected by the heart rate, but then even after taking into consideration the effect of the blood pressure, taking into consideration the effect of the heart rate, just looking at the CVP waveform in itself, there is a statistical difference between what happens in jet versus sinus rhythm. So our goal is like, by combining the EKG waveform with the morphologic parameterization, like looking at the various, bits and pieces of the EKG, and on top of that, adding the CVP waveform, this will make for a very sensitive and a specific indicator for this particular arrhythmia called as junctional ectopic tachycardia.
And it really looks like you're achieving some good statistical significance here, right?
No, definitely. I mean, and again,
Very
this
strong.
is very promising. Yeah, this is very promising. Like, like as I mentioned, like, there are, like, we as a clinician always knew these are some of the telltale signs in there, like, but haven't been able to get the mathematical statistical modeling computing to find the exact difference what happens. So yeah.
I can see how you think this is fun. I'm watching this and having worked with audio and laser light waves, similar type analysis. It's fascinating to get into these algorithms and try to work this stuff. So let me ask you, once you're able to deploy this or implement it, what is the expected result from these different approaches?
So as I mentioned, Bruce, like, currently there are no algorithms to detect jet. Like, it's kind of funny that I say this because, like, it's one of the most common postoperative arrhythmias. And I think this is where the innovation in pediatrics in general has lagged behind. So, like, we'll talk about that a little bit more. But then the impact, I think, like, like one of the unique aspect of this one is we in the ICU, and a lot of my colleagues will attest to it, like, we have a concept of alarm fatigue. What alarm fatigue is, like, all the bedside monitor alarms that are built in, they are designed to be sensitive, all for good reason. Like, you want to pick up each and every significant event that is happening. But in doing so, they have made it to be so sensitive that oftentimes there are false alarms. Depending upon which study you read, they say, like, some of these alarms are like as high as 90% of the alarms that we deal in the ICU are false alarm. And you can imagine, like, being a bedside nurse who have, like, 20 different medications to give, like, so many orders to follow. There will be a time, and on top of that, if you have to go and tend to each and every alarm, so, like, all we end up going and muting or silencing the alarm without really paying the attention that oftentimes is needed. So the alarm fatigue is pretty significant, and it contributes not only to, like, the clinical burn or, like, just another thing to go out and another thing to take care of, but it can be dangerous. It can definitely lead to some inaction when the action was needed. So whenever, like, whenever I've embarked upon this journey, like, I was always mindful, okay, like, I don't want to add more to the problem. Like, how can we come up with a creative solution, like, where we create an arrhythmia detector that not only is sensitive, but also specific. So, like, the different part or the unique aspect of this approach is we're not using the traditional EKG waveform only for detection of arrhythmias. And this is where majority of the bedside arrhythmia alarms are. They are operating on the EKG. Don't take me wrong, like, EKG still remains the gold standard, but, like, we wanted to, there are definitely nuances to the EKG as well, depending upon how the leads are placed, depending upon the patient movement. So our goal is to avoid alarm fatigue that happens. So, like, we come up with something that is important and something that is actionable as well. So, like, whenever the clinicians are responding to it, they know they are dealing with something significant.
So very interesting. So after you've built this algorithm and figured out, how much alarm fatigue you can tolerate, because there's always a little bit in some of these algorithms, right? What is the next step? How do you plan to validate this algorithm?
So I guess, like, the biggest first step for me is, as I mentioned, like, the jet is so deceptive. Like, we don't even know what the arrhythmia burden is at this time. Like, there is general feeling in the clinicians, world that we often are a bit late when we are reacting to jet. by the time it becomes significant that a bedside nurse is alarmed by it or alerted by it, the patient has already seen a significant impact of it. It might be that the onset was so quick and it was so devastating that the nurse couldn't really think, or the bedside clinician couldn't really do anything to respond to that. So our next step is to have an intuitive visualization of this algorithm. So we want to create a visual model for the clinician that they can go back and see where they're validating, this is definitely an abnormal arrhythmia. And then the first step, as I mentioned, we want to go and have an appropriate, timely diagnosis of GED. And the next big step for me is, as I plan out my next step in the research, is we wanted to minimize the anti-arrhythmic or the pharmacological interventions that is needed at times to rein this rhythm in and trying to convert back into sinus rhythm. Again, there's no data out there, if you intervene with some of the non-anti-arrhythmic pharmacological intervention, sometimes what we do for these patients who are having these kind of arrhythmia, we try to avoid any stimulation to them because we know that every time they are agitated, they are stimulated, this arrhythmia gets worse. So at least the clinician who's taking care of this patient will be more thoughtful, mindful. And then we can introduce some other therapies, making the patient's temperature go low so that we are not heating up the body if unnecessarily, or even actively trying to cool it down. We can try to keep the patient more sedated. We can even think about how we can decrease the body's oxygen demand over a period of time. And the hope is with that, maybe we can keep a subset of patients without needing the anti-arrhythmic agents. We don't know whether that's going to be possible or not, but in terms of next step, our goal is to have a stepwise intervention so that we can A, identify the burden, B, identify the timeliness of diagnosis, C, then identify which of these therapies are most useful, and then in different combination. Not uncommonly that it happens in the ICU that we end up, when the patient is so sick, that we end up throwing kitchen sink on them. We're just trying to make sure that we're not seeing any significant complication. But again, our next step for clinical validation is to come up with a guideline for the bedside clinician, do step A, B, and C, and then that way we can quantify and measure, what interventions are able to help which one.
Well, that sounds great. We'll all be looking forward to that validation and the deployment of this algorithm. And I think you might have touched on it, but beyond the validation of the algorithm itself and the creation of these alerts, what's next relative to your research into this condition?
You know what? I think the possibilities are endless, to be honest, because I'm just starting, and I think what I feel is the exciting part of this research is we are looking at what I feel is multi-modal alarm. So typical alarms are usually looking at each of those bedside system, either EKG or the venous pressure or the blood pressure in isolation. There hasn't been anything that has developed that has combined everything together. So I think this is definitely very useful. So, and it becomes even more meaningful, especially in the pediatric cardiac ICU world, because the physiology is ever changing. The way I think about cardiac ICU is what it still is in early childhood in terms of evolution. So imagine what pediatric cancers were in 70s, 80s. People were just trying to figure them out. They're trying to keep the therapies. And now the expectation is they should have very good survival and now the quality of life. We have come a long way in congenital heart disease. The surgical techniques have been really well mastered. So survival is pretty much expected at this point. So now we are thinking about how do we keep them alive with a good quality of life. And then we are seeing a unique patient population called the adult survival of congenital heart disease, so the ACHD population. But you can imagine, that heart has taken a significant toll over a period of time, so we'll see a lot more evolution and change in the physiology that happens. So we have to look beyond one particular source for an alarm or a monitor. We have to be able to combine that so that we can even define what are the changes that are happening in a timely manner, so that when we think about the long-term outcome for these patients, we can definitely do everything we can to improve their quality of life. And then what we also want to do is, and again, part of my project would be like, we know that MIC is available at different pediatric centers, and then so we can start collaboration across different data sets and different institutions, and then we can even account for variation in practices that happen at different places. And then this, again, will only lead to better clinical outcome for such a unique patient population in the future.
Well, that sounds great, Dr. Jain. Thank you so much for all this great information. And I must admit, I am jealous watching you work through your algorithm and work through those waveforms. That's very fascinating work in the area of automating the detection of jet. We do have a number of questions that have come in from audience members. I'm going to turn it over to Raj Patel. We just have a couple minutes for this. Raj is MIC's Director of Research. He'll help moderate and facilitate those questions. Raj, are you there?
Hi, Bruce, can you hear me?
Yes, I can. There you go.
Great. Yes, if you haven't yet and you have questions, please click on the Q&A button and submit some, and I'll read them off so that Dr. Jain can answer them.
Cool.
We have one coming in, and the question, Dr. Jain, is, what would you recommend to someone who wants to bring together clinicians and statisticians to do the kinds of work that you're doing? How would I get started, for example?
That's a great question, Raj. I think the first step is to be able to challenge your own conventional thinking, trying to break the silos, that I would say. So when I approached this problem, I knew, if I keep looking at the same thing, I would add to the alarm fatigue. So, think outside the box, try to think for a solution that is a bit more sustainable. And then what I strongly believe in after doing this is trying to break the silos, thinking about, how I can try to bring some other expert that are available that can definitely help with the problem. And then again, for someone who's trying to start into this one, I would even say, try to have a very specific question, what you're trying to achieve, because as you can imagine, with any big data, you can easily get lost, and there can be so many ramifications. But then if you are able to stay true to yourself, this is my primary question, am I able to get to that point? I think it will help the whole team stay focused for sure.
Those are really, really good points, and I hope folks take that advice. All right, that actually, unfortunately, that looks like that's all we have time for today. So I'm going to turn it back to Bruce, and any questions that we didn't get to answer live, we'll answer directly. We'll have Dr. Jain answer directly. So thanks, and Bruce?
Yes, I'm here, Raj. Thanks very much. And again, we do want to respect folks' time, so we're going to wrap up right at the half hour here. Just to let everyone know, we will make Dr. Jain's research a replay of this webinar and an audio podcast version available after the webinar completes. Thank you, everyone, for joining us in this edition of our Healthcare Data Matters webinar. We hope you can join our next session on December 8th, where Dr. Danielle Rios from the University of Iowa Healthcare will be discussing neonatal hemodynamics, which is a growing specialty that is directly impacting patient care. In the meantime, you can visit our website for more information or check out our associated social media channels. And thank you again for joining us on Healthcare Data Matters. We are grateful to have the opportunity to advance a new standard of patient-centered and data-driven care. Take care, everyone.
Thank you so much.